So I've been asked to address this topic on quality issues and indicators for ambulatory surgery. And before I do that, let me give you a slight idea where I work as an anesthesiologist in this 700-bed central university in Porto, that is the second city of my country, Portugal. And we have 2 or 3 main buildings. This is the main hospital in the center of the image, with a very old building with more than 200 years, a new facility, and then 2 new units. The one that is here, the day surgery unit that is open for the last 2 years, and a maternity unit that is nearby. You can see in the picture. So we are used to defend ambulatory surgery with several lists of advantages for patients, like a patient-centered treatment, less disruptive environment, reduced patient-acquired hospital infections, reduced rate of complications, higher patient satisfaction rate, easier scheduling and registration process, quicker functional recovery, and sooner return to social and professional life. And also for our hospitals, more efficient management of non-emergent surgery. Inpatient beds can be released for new cases or even to be closed, cost-effective comparing to inpatient surgery, improve patient turnover, and reducing waiting lists. But sometimes the method is not understanding well for our patients. But can we confirm all these advantages? Is patient being the center of our attention, and is he satisfied in any or all over the situations? Do we have reduced rate of complications? Are our patients recovering faster than inpatients? Are the inpatient beds being released for new cases or closed? Are we being more efficient in management of non-emergent surgery? Are we improving the patient turnover in our daily work, or are we reducing our waiting lists? So, the following question is, how often do happen cases like patients that fail to arrive at our day surgery unit, patients that feel sick with pain or nausea and vomiting and don't have fulfilled the discharge criteria to go home, or patients that don't have an escort to leave the day surgery unit, or even those that, being discharged home, return to our day surgery unit due to wound hemorrhage. And do we know really the data for that questions? And they are more often than should be acceptable. So I think that we should look after our results, our outcomes, in order to prove that we have, in fact, a continuous quality improvement in our programs. And one of the countries that looked after the clinical indicators for a long time ago is Australia. And if you go through his website, you can see not only for the surgery activity, but all type of indicators in healthcare system. And they picked these 4 indicators for the day surgery programs, like the cancellation of booked procedures, unplanned return to the operating room, unplanned overnight admission, and unplanned delay in patient discharge. And at the IAS, we picked others. The first 3 that I've shown to you before, and another ones that should look as for the postoperative period, like the unplanned return to the patient to the day surgery unit or hospital, the unplanned readmission of the patient, and the patient satisfaction. So if you go through the literature to find what is going on this topic, we can see that there is a lack of documentation about how major illness are treated in most healthcare systems, a lack of systematic outcome assessment, a lack of research evaluation related to quality for specific diseases, persisting variations among providers in care for similar patients. There is much more a culture of eminence than evidence-based, that few formal monitoring systems are in place by healthcare providers or regulators. And indicator measuring and monitoring make possible to document the quality of care, do comparisons, benchmarking between hospitals and even between the same hospital to control this activity over the years, establish judgments and set priorities, support accountability, regulation and accreditation, support quality improvement, and support patient choice of providers. And so with all this lack, IIS thought that could be a good idea to make a project under this subject, under looking for new clinical indicators, a setting of indicators that we could use all over the world. And we established this day surgery data project, and you can go through the internet, the website, with www.bstp.eu for European Union, and you can see all the reports around this. And for tomorrow, you'll have another session on this subject as well. So the project that we concluded last year aimed to identify a valid and validate a set of indicators and to develop the information systems on day surgery in Europe. Because we realize that there is a lack in the clinical indicators on day surgery, but there is a lack in informatic systems to collect these data and to be possible to have these indicators. And this project proposes also to analyze the surgery data and health indicators, both at the international organization and the member state level. So we try to look all different dimensions of performance of the surgery. So as you can see here, from input, patient's characteristics, access, process, output, outcome, safety, satisfaction, responsiveness, and cost productivity. All of these items would have special clinical indicators. And we picked a list of a represented set of procedures representing different surgical specialties, as you can see here, and they are very representative from the OECD data collection. And from cataract surgery, tonsillectomy, varicose veins, laparoscopic cholecystectomy, inguinal femoral hernia repair, prostatectomy, hysterectomy, breast conserving surgery, mastectomy, and knee arthroscopy. And what we did was to try to have a consensus around an essential setting of day surgery indicators at the national, regional level and at day surgery unit level. So in two different levels. And then another setting of indicators, not essential, not basic, but more ideal. And for the essential setting, you can see here that in the different performance, input, access, output, outcome, you have several indicators. Input with number and percentage of day surgery units. For the access, medium waiting time for the basket list. Output, like the percentage of the elective surgery performed as a day surgery for the basket list. In outcome, case fatality ratio within 30 days of basket list, and the percentage of day surgery unplanned overnight admission, the percentage of day surgery admissions returned to the operating room within 1 week, and in terms of safety, the percentages of admissions with wrong side patient or procedures in the context of the SAFE surgical checklist. In cost and productivity, the expenditure on day surgery care as an absolute value and percentage of total healthcare expenditure. So you have several different dimensions of performance level. And this was at day surgery units. Again, I will mention only the ones on blue because the other I have mentioned before. So we add another indicators like on the process list and outcome for those patients that go, they have been discharged and then are then readmitted to day surgery unit as well. On safety, the percentage of day surgery surgical wound infections at satisfaction responsibly level, the percentage of patients overall satisfied, and in terms of cost and productivity, those that are cancelled, patients that are not performed at all. And at the ideal set as you can see here, there is about 15 day surgery indicators. For those who are really interested in this, I would address our website to look for these results. And in the ideal set for day surgery level, it would be about 30 different day surgery indicators. There is a lot of many indicators that you can look for. And to try to demonstrate a little bit how this work can be done, I would give you some examples of the data that of my unit just before the beginning of the new day surgery unit. This is data from 10 years' time, a decade, and you can see for the outcome for day surgery unplanned overnight admission and the unplanned readmission to hospital or to day surgery unit within 1 week. We have only collect for the first 24 hours, not 1 week, but 24 hours. You can see from the rate that we have dropped from 1.6 to something that is always below 1%. Okay? The idea is not to be on the zero level. It gives the image that you are not going to risk, not make challenging new cases, but also to have something controlled under the 1%. And the return to hospital 24 hours after surgery, you can see here, that is below 2%. For safety reasons, we can look around pain not controlled within 2 and 24 hours, So what we have done, we look for our most painful procedures, that in our case is hemorrhoidectomy, varicocelectomy, bilateral inguinal hernia repair, and you can see that in green that it has been established for all these decades. And then you can see for those cases in red that are patients that report a visual analogic scale more than 3 in a scale from 0 to 10. So moderate and severe pain. And these patients, unless 2004, that was when parecoxib was introduced in the market, we thought that this drug could be safer and as effective as ketorolac, and we changed to that. So what we found is that we have an increased rate of patients with more pain. And then we turn again to ketorolac, and we notice a decrease in the next years. Even those that are severe pain are quite controlled. They are just single cases, isolated situations. For nausea and vomiting, you can do the same. And if you go through the decades, we have a routine use of antiemetic drugs like droperidol and dexamethasone, and we can control these under 2% of cases with isolated situations of nausea and some isolated situations of vomiting as well. What about cost productivity? When we began to look at this data, we have about 10% of patients that were cancelled, some that failure to arrive, and less than 6%, about 3.2, cancel after arrived to day surgery for medical problems, for organizational problems, different situations. But when we try to better organize our day surgery unit, we found that after 10 years, we followed about half the initial rate, about 5%, as you can see here. And of course, this is a continuous process. We should improve more and more in new years. And what about cost productivity and the percentage of utilized theater sessions over weekly plans? You can see also that at the beginning it seems everything perfect, but we noticed that many cases were not performed, so we were using under-utilize our theater sessions. So we improved that, as you can see, till over 90% of the time. So to conclude, I would say that emphasis was pointed out on the importance for developing a safe, effective, efficient and satisfying high-quality play surgery program. We show that the evaluation of our day surgery practice should be done through the implementation of indicators, and the implementation of indicators are the best way to improve the quality of our healthcare services. And thank you very much.
Thank you very much.